Hi friends, in today's class we will discuss about normal tension glaucoma, its mechanism, risk factors, clinical signs and symptoms, investigations, diagnosis, the indications for neuroimaging, management and clinical trials. So coming to what is normal tension glaucoma, so it's also referred as normal pressure or low tension glaucoma. So what are the clinical features? What is the triad of this? So there should be, so in glaucoma we have IOP changes, visual field changes, and optic nerve head changes. Right? So that is triad of glaucoma. But here we have visual field changes, optic nerve head changes, but the IOP is normal. So it is consistency equal to or less than 21 mm of Hg. So along with, there should be no other identifiable cause. So this is the definition of normal tension glaucoma. So coming to its the mechanisms of this. So we have mechanisms of the IOP mechanism. We have a genetic, ocular, vascular abnormalities, systemic vascular abnormalities, and hematologic abnormalities. So coming to what is IOP mechanism. So there can be IOP which is high normal in range. So that is the high teens, 18s to 20. That is one mechanism. And in the other mechanism there can be high diurnal variation. In the genetic we have optineurin, gene mutation, and OPA1 gene mutation. That is also seen in dominant optic atrophy, that OPA1 gene. And coming to ocular vascular abnormalities, we have reduced ocular pulse amplitude, focal arteriolar narrowing around the optic nerve head, increased vascular resistance in ophthalmic artery, which is seen on color Doppler. Then we have systemic vascular abnormalities that includes hemodynamic crisis, increased nocturnal BP drops. So that is systemic hypotension can also contribute for it. Then we have vasospasms and Raynaud's phenomena, and also migraines. And hematological abnormalities, we have increased blood viscosity, hypercoagulability, hypercholesterolemia, and autoimmune factors. Okay, so these are the mechanisms. Now coming to what are the clinical features. So we have, so this present mostly in older age group, which is above 60 years, and usually in females, and Japanese origin. On checking the visual fields and optic nerve head evaluation, we can find there is thinner neuroretinal rim, especially inferiorly. There can be optic disc hemorrhage, retinal nerve fiber layer defects. These are more localized. We have large areas of parapapillary atrophy, especially in zone B. And on visual field examination, we can see a deeper and more localized scotoma, which is closer to the fixation. So this is called shotgun appearance. So instead of multiple farly spaced, we can see a very much nearby spaced defects in the visual field analysis chart, which gives the shotgun appearance. Okay, so we have discussed clinical features, mechanisms, signs and symptoms. Now coming to investigations and diagnosis. So the investigations and diagnosis should include all the tests which we have seen are related to the etiology. So in the etiology we have said 5 mechanisms, right? So we have to exclude all those with the help of investigations in these patients. So what are all the investigations which we can perform? So starting from the history part, we have to take thorough history of the patient with regards to any previous elevations in the IOP, any steroid use, and the use of beta blockers, hemodynamic crisis, anemia, blood loss, low BP, stroke, and all this history we have to take. When we have to do some blood tests, so just to rule out other causes, for we have to perform CBC, ESR, CRP, okay, autoantibodies for immune causes, and vasculitis, all these. Then we have to perform some radiological investigations, such as cranial MRI to rule out any cranial causes, and carotid Doppler for imaging of carotid arteries. Then we have to also perform ocular tests. So we have to measure first intraocular pressure. So it should be done by GAT, and we have to measure diurnal variation on different days, different time, and sitting and supine position. All these variations we have to look, and we have to, on slit lamp, we have to rule out other causes of open angle glaucoma like pigment dispersion, there is any pseudoexfoliation, any angular recession, all those things. Then in gonioscopy, we need to look after any angle closure, recession, and pigment dispersion. And we also should perform other tests like blood pressure measurement by 24 hours ambulatory monitoring, especially those who are hypertension patients. So this can be done with the help of 24-hour ambulatory monitoring. This was regarding investigations and the diagnosis part. Now we will discuss what are the indications for neuroimaging in these cases. So it includes general and ocular. So in general and ocular. So we need to perform if the age is less than 50 years, because it's common in old age above 60, and if there are new onset or very severe headaches, there are focal neurological signs and symptoms, and neurological visual abnormalities. So when we see in the fundus, they will be respecting the vertical meridian. In coming to the ocular, we have color vision abnormalities, pallor of the neuroretinal rim, very much asymmetric cupping. So there is no correlation between the optic nerve head and the visual fields respecting vertical meridian. So these are characteristics of neurological disorders. Now coming to the treatment part, there is medical management as well as surgical management. In medical management, we have the preferred drug is topical beta blockers. So example are betaxolol. So this betaxolol is very useful because it has neuroprotective. So this is the drug of choice in these patients, and here the target IOP is 30% reduction. Then we can also use alpha agonist, brimonidine. It also has neuroprotective. So both these are neuroprotective, brimonidine from alpha agonist and betaxolol for beta blockers. Both have neuroprotective role. We can also use carbonic anhydrase inhibitors like dorzolamide. And calcium channel blockers like milnacipran and brovincamide. So this brovincamide is a nimodipine-like agent. So these are reserved for the patients whose glaucoma is deteriorating despite the regular topical agents and surgeries. So it addresses vasospasm and improves the blood flow to the nerves. Okay, then we should also take care of some systemic conditions. So we should control the systemic vascular diseases like diabetes, hypertension, hyperlipidemias, anemias, and also that should be taken care. And we should also anti-hypotensive measures. So if there are more nocturnal dips, we have to reduce the antihypertensive medications. We can also use neuroprotective agents like memantine, ginkgo biloba, antiplatelet agents. And in surgical procedures, we can perform full thickness filtering surgeries. So these are indicated when the IOP progresses despite low IOP. The optic nerve head or the visual field changes, they are progressing despite reduction in the IOP, and also in patients whose baseline IOP is in the upper teens, that is in the high normal range. So we can perform antimetabolic enhancement of TRAB with or without mitomycin C in order to achieve it. So this is a better option for achieving the IOP. So the laser trabeculoplasty SLT can be used, but it is of argon laser trabeculoplasty is of not much of useful. Now coming to the studies, we have the collaborative normal tension glaucoma study. So in this study, the patients were aligned to either observation versus treatment. So it was found out that IOP should be at least reduced by 30%, and the treatment is recommended if the neuropathy is progressing, and almost 65% of patients did not progress. Then we have low pressure glaucoma treatment study. So it says timolol is not useful in reducing the IOP. And we have early manifest glaucoma trial. So in this it says ALT is not useful. We have to perform filtering surgery. If the IOP and the disease is progressing despite medical management. So this was regarding normal tension glaucoma, the A to Z of normal tension glaucoma. So I have done extensive study of the treatment and the indications part, everything. So please, I request you all to subscribe to my channel so that it gives me an inspiration for you to prepare such useful content. Thank you for watching the video. Bye.